be enough. Dr. Suyama, thank you very much.
Good morning. My name is W Sumaya. It's a great pleasure to be here with you today. And thank you to the organizers for organizing this exciting meeting. I'm doing this talk on behalf of Professor Story from Sheffield, who unfortunately couldn't be with us today due to a bike accident. And these are Rob's disclosures. So there are three areas where I would like to discuss with you today where there are opportunities and challenges for antithrombotic therapy and stroke risk reduction and also stroke prevention. So there are the patients who are at high risk for atherothrombotic disease, and that includes patients with coronary artery disease and or peripheral artery disease with multiple risk factors. The other patients are patients with atrial fibrillation and who also need antiplatelet therapy, either because they've had PCI or presented with acute coronary syndrome as well. And lastly, patients who present with minor strokes or TIAs. So the first cohort of patients who have coronary artery disease and or peripheral artery disease with multiple risk factors. And there are two main trials that have addressed this issue. So the Pegasus TIMI-54 trial was aiming to recruit patients within 1 to 3 years of having a myocardial infarction. They had to be of a certain age, over 50, and have also additional risk factors, either diabetes, peripheral artery disease, or chronic kidney disease not needing dialysis. Compared to antiplatelet therapy with aspirin and ticagrelor at 2 different doses to aspirin monotherapy alone. And we can see in this slide that ticagrelor did very well, and it reduced major cardiovascular events significantly compared to aspirin monotherapy. And when we look at the number of strokes in patients who received ticagrelor 60 milligrams twice daily, and that's the approved dose for prolonged DAB therapy, there is a significant reduction in the moderate to severely disabling stroke in these patients. Of course, there is a penalty, and that was at the expense of an increase in non-fatal major bleeding events. And as you can see there, there is no difference in fatal bleeds or intracranial hemorrhage between patients who are on DAPT or on aspirin monotherapy. Now, ticagrelor works by inhibiting platelets, so it inhibits platelet P2R12 receptor. And we know that platelet and coagulation is very closely linked. So the activated platelets play an important role in thrombin generation, So by inhibiting platelets with P2R12 inhibitors, that may have an indirect anticoagulant effect by inhibiting thrombin generation, Similarly, when we give anticoagulants, that inhibits thrombin generation, and thrombin is a very powerful platelet agonist through the PAR receptors. So anticoagulants may have an indirect antiplatelet effect. So that leads us to question whether anticoagulants may play a role as well. So we know that there's also the COMPASS trial. So COMPASS recruited high-risk patients for atherothrombotic disease, and that includes patients with coronary artery disease who have multivessel coronary artery disease and or peripheral artery disease. And 60% of patients had myocardial infarction in the past. And they compared the addition of low-dose rivaroxaban, 2.5 milligrams twice daily, in addition to aspirin alone, or rivaroxaban 5 milligrams twice a day, compared to aspirin alone. And as you can see, the combination of aspirin and rivaroxaban did very well, and they improved major cardiovascular events, including a reduction in cardiovascular death. Whereas the rivaroxaban alone treated group rivaroxaban alone didn't significantly reduce the risk of major cardiovascular events. So this indicates that some antiplatelet therapy is needed in this cohort. And if we look at the stroke risk reduction in COMPASS, it was very impressive. there is 42% risk reduction in terms of stroke. So that is really highly significant and very impressive. Of course, that was at the expense again for increased risk of non-fatal major bleed. And as you can see there, fatal intracranial hemorrhage were no different between dual antithrombotic therapy with aspirin and rivaroxaban compared to aspirin alone. So we move on to the other complex issue, which is patients who need antiplatelet therapy because of PCI or acute coronary syndrome, but also need anticoagulation because of atrial fibrillation. This is a very complex area. There were two major trials, the Pioneer and Redual PCI. They had some limitations. For example, Pioneer tested a low dose of rivaroxaban, 15 milligrams, as a dual therapy approach with clopidogrel compared to triple therapy with warfarin, so it's not really a fair comparison. And also tested triple therapy with a non-approved dose of rivaroxaban 2.5 milligrams twice daily, in addition to aspirin clopidogrel. And Redual PCI again had the similar limitations. Nevertheless, there is a consensus document, and at present in patients who have a high risk who are at high risk for fatal bleeds, oral anticoagulant and an antiplatelet agent may be acceptable immediately after PCI, but of course for those who are at high risk for ischemic events, triple therapy is still indicated. We're waiting for the results of the Augustus trial, which is due to be announced in the ACC meeting this year. And Augustus was a much bigger study, so recruited 4,600 patients and compared a vitamin K antagonist to a NOAC, in this case apixaban, and also tested dropping aspirin to see whether we can do with just dual therapy from the start. So we look forward really to the results of this, because this will inform the field further. If we move on to patients who present with a TIA and minor stroke, we know that aspirin is indicated, but is there a role for a dual antiplatelet therapy approach? There were three major trials, but the meta-analysis of these three trials indicated that dual antiplatelet therapy with aspirin doesn't really present very well there. But dual antiplatelet therapy with aspirin and clopidogrel reduced the recurrence of stroke without a clear penalty of increased bleeding risk. However, the all-cause mortality for dual antiplatelet therapy, apologies for this slide, doesn't present very well, I don't know what the issue is. So the all-cause mortality for the DAPT, the point estimate, doesn't really favor dual antiplatelet therapy approach in this population. So the SOCRATES trial tested whether ticagrelor monotherapy is better than aspirin monotherapy in those who present with a TIA or minor stroke. There was a trend for benefits with ticagrelor, but this missed significance, p-value of 0.07. So this led us to question, is dual antiplatelet therapy with aspirin ticagrelor beneficial? So a subgroup analysis was done, and patients who were pre-treated with aspirin before the trial and then they received ticagrelor did well. So this is, of course, hypothesis generating finding, and on the basis of that, the THALIS study is ongoing now. So this is testing aspirin, dual antiplatelet therapy with aspirin ticagrelor compared to aspirin in those who present with a TIA or a small stroke. So in conclusion, there is a role for intensive antithrombotic therapy, whether that is with aspirin and ticagrelor, 60 milligrams twice daily, in those who have had myocardial infarction with additional risk factors, or aspirin and rivaroxaban 2.5 milligrams twice daily in those who have multi-vessel coronary artery disease and or peripheral artery disease. And that leads to a reduction in stroke risk. In patients who have ACS or who have had PCI and also need anticoagulation for atrial fibrillation, we acknowledge that this is a very complex area but the results of the Augustus study in the ACC will inform the field further. Currently, only in very high-risk patient, bleeding risk patients, oral anticoagulant and an antiplatelet agent is recommended. Patients who present with a TIA or a minor stroke, aspirin and clopidogrel reduced recurrence of stroke, but there was no evidence of improved mortality with this approach. But currently the THALES study is ongoing to test whether aspirin ticagrelor may be superior to aspirin monotherapy. And with that, I'd like to end the talk, and thank you very much for listening.